Hey, good morning, everyone. Truly a pleasure to be here. Truly an honor to be allowed to speak at the legendary THI. And I have to say, I'm extremely proud that Medical City Children's Hospital is now a THI clinical rotation for the students. So very happy to be on your team right now. And I'm going to claim a little bit of that THI swag. I've been in Texas 16 years now, and I'm claiming it. I'm keeping it. So I am the director of perfusion at Medical City Children's Hospital. We are a pediatric program. We are a private practice children's hospital within a large adult medical campus. We have a congenital heart surgery program, pediatric cardiac cath lab, pediatric EP lab, pediatric ECMO program, both cardiac and respiratory, pediatric general surgery. We have a few specialties, specifically cranial facial surgeries and pediatric spine surgery. We also have a very robust labor and delivery program. We have a maternal fetal program. We have a maternal transport team, and we have a recent placenta accreta program. With these programs combined, what gives us an advantage at Medical City is we have the ability to take care of both the mother and the baby in the same facility, in the same tower, really just one floor apart. Team, we have two congenital heart surgeons, 4 pediatric cardiac anesthesiologists, 2 interventional cardiologists, 4 perfusionists, 4 circulatory support specialists, and I'll get into that specific position later. We have 30 ECMO specialists that sit around the clock bedside. Service a cardiac intensive care unit, a PICU, we have a level 4 NICU. As far as our women's team, we have 4 maternal fetal cardiologists and 2 placenta accreta surgeons. As far as heart cases, we're on average total heart cases, bypass and off pump. We're in the 350 range. And I went back to 2017. Prior to that, we were 350 to 420, I think was our biggest year. In 2019, our program actually shut down. Our surgeon moved on to a different program, so we were closed for a bit. In 2020, we hired our 2 new surgeons, and we quickly ramped back up. And last year, we got close to that 350 mark. This year, we're well on our way to head more closer to 400. As far as pump cases, we average closely to 200 to 230 pump cases. Again, we shut down in 19, and now you can see we're slowly ramping back up again. We average annually about 20 ECMOs. Busy year was 29. Last year we did 17, but if you look at the hours, we had close to 6,300 total ECMO hours, primarily respiratory. So in 2019, when we had the lull in action with the heart program, we started a blood management service. So we did all the cell savers in the hospital. And now we primarily focus just on women's and children's autologous cell saving. Again, the first year we started, we were around 100 cases, and now we're up to 200. This year, we're heading more towards 300. So with the new surgeons, we had some staffing dilemmas. We restarted the end of 2019. Our two new surgeons wanted 2 perfusionists per case. We had an increase in non-cardiac ECMO, and that was associated to a maternal fetal surgeon who specialized in congenital diaphragmatic hernias. We initiated the perfusion-based blood management service. The surgeons required us in-house in the room for standby for all non-pump cases. We're in-house standby for all high-risk cardiac cases. When patients 4 kilos or less, we wash the bank blood. And of course, on top of all of that, we have our point of care management and our equipment management and heater cooler cleaning. So we had staffing issues. So the increased responsibility in women's and children's. Another thing I want to mention is perfusionists require 40 primary clinical cases to remain certified. Now, the ABCP does allow 25 primaries and 15 secondaries, but at Medical City, we feel like you have to do at least, at a minimum, 50 bypass cases to stay competent. So as far as cell saving, washing the blood, and ECMO monitoring, we feel that perfusion is required for total oversight over these programs with qualified personnel conducting the procedures. And this is where our circulatory support specialist position came to play. That person is a hybrid ECMO specialist with special training in extracorporeal technology and blood management modalities. Qualifications we require for a circulatory support specialist are they must be a registered nurse or a respiratory therapist. They must have 3 years pediatric critical care experience, either a PICU, NICU, cardiac intensive care, pediatric cath lab, or pediatric transport team. They must have completed an approved ECMO training program with 3 to 5 years of ECMO specialist experience. And they must possess critical thinking skills in stressful situations. So the job description, specifically to ECMO, they are the primary care providers for respiratory ECMO with perfusion oversight. This includes initiation, decannulation, and surgical procedures involved while on ECMO. They assist the perfusionist with cardiac ECMO. Cardiac ECMOs tend to be transitioned from bypass to ECMO or ECPR. So perfusion is the primary care provider in that situation. The circuit support specialist maintains the circuit, patient monitoring, and does in-house ECMO transport. They provide the education, wet labs, clinical competencies for all ECMO specialists. They schedule and supervise the ECMO specialists. They maintain all the equipment, and they maintain the ECMO data, the ELSO database, and they do the Center of Excellence application. We've been a ELSO Center of Excellence recipient for 12 years now. Last one, we received the gold standard. In the operating room, they provide perfusion support. They have the ability to set up all bypass circuits. They operate the cell saver. They wash the bank blood. They operate all point of care tests and analyzers. They do the QCs on those analyzers. They assist with transition from bypass to ECMO, and they help maintain the equipment. And as perfusionists, you'll be happy that they clean the heater coolers. It's one thing off our plate. As far as blood management service, we just don't do or operate the cell saver. We actually have introduced point of care testing into those procedures. We've introduced the TAG monitoring for patients that are bleeding heavily. And we found that we are the best people perfusion as far as getting blood rapidly from the blood bank with our experience in the open heart theater and with ECMO patients. Our staffing model, it follows the traditional N+1, surgeon +1. So we have 2 CV surgeons. We count the general surgery group who does the respiratory ECMOs as 1 surgeon. So that's 3 surgeons with an N+1 of 4 perfusionists. So we've lined up each perfusionist with 1 circulatory support specialist. We have 30 ECMO specialists that sit around the clock and monitor the ECMO patients. These are either PRN personnel, or it is a secondary position in addition to their RN or respiratory therapy position. All bypass cases are conducted with 1 perfusionist, 1 circulatory support specialist. All standbys have 1 perfusion, 1 circulatory support specialist. And of course, 24/7, there is a perfusionist with a circulatory support specialist on call. So a typical day, if we have a heart case on bypass, that's 1 perfusionist and 1 circulatory support specialist. If we have a placenta accreta case, that's a cell saver with 1 circulatory support specialist. If we have 1 patient also on ECMO, that's an ECMO specialist bedside, a circ support person checking on them with complete perfusion oversight. We're 1 perfusionist, 1 circ support for all standbys. And generally, when we make incision on the open heart case, our 2nd perfusionist is coming in-house for emergencies, ECMO, anything else that may arise during the day. And again, 1 perfusionist, 1 circ support on call. So to come to this model, we decided the formula or the dilemma was 2 perfusionists versus 1 perfusionist plus 1 circulatory support specialist. So as far as the analysis, we shot high. We said, okay, let's consider 200 to 250 pump cases, 25 ECMOs with 2 perfusionists per case. So we estimated a good number just for bypass and ECMO to be a staff of 6 perfusionists. We did a market analysis of wages in North Texas. We also did an analysis of 6 pediatric programs around the country. And our final result was the cost of hiring and training 4 circulatory support specialists offered a more viable option at a cost 50% less than hiring 2 additional perfusionists. Clinical advantage. For a perfusionist going on bypass, you have an extra set of hands. You have someone running your labs. You have someone who can grab that extra percutaneous cannula. We have redundant ECMO specialists, circ support, perfusion, as far as ECMO support for the patient. We have blood management support, point of care testing support, and data management. With this model at Medical City, we are now invited to the maternal fetal conferences, pediatric code blue conferences. We have a seat at the table. We're very involved in all programs at our facility. So to my new teammates, students at THI, I'll leave you with this. Perfusion education and perfusion clinical training goes well beyond extracorporeal technology. Our training and our experience really enhances other programs within the hospital. And that is very recognized by administration. And when administration sees that, you have a seat at the table. And when you have a seat at the table, you can advocate for the perfusion profession. And for your time and look forward to any questions.